Good evening, everybody. Welcome to this case presentation. Hari, our senior postgraduate, is going to present this case on thyroid. Particular welcome to all the seniors here, Shrikant, Ramakrishna, Dr. Guru Shantappa, and others. I'm sure we will have a very useful discussion because this is one of the common cases that students get in the final exam, be it MS or DNB. Over to you, Hari.
Thank you, sir. Good evening, everybody. I'm Dr. Hari Arasaran, final year DNB resident, Sagar Hospital. So today I'm going to present a case of a 56-year-old lady. She's a homemaker coming from Nazirabad, Kolkata, and Hindu by religion, and she belongs to lower middle class socioeconomic status. Next slide. She presented with chief complaints of swelling in the anterior aspect of the neck since past 3 years, which was rapidly increasing in the size since the last 4 months. Patient was apparently all right 3 years ago. Then she noticed swelling in the anterior aspect of the neck, which was insidious in onset and initially small in size and to reach the current size. And swelling was rapidly increasing in the size since the last 4 months. And she also have discomfort over the swelling since the last 2 months. She has no history of difficulty in breathing or difficulty in swallowing. She has no history of any change in the voice or a stridor. She has no history of any other swelling in the neck. Patient also has no symptoms suggestive of any hypothyroidism, and there was no history suggestive of any distant metastasis. Coming to the past history, she's a known case of hypertensive, which is since 1 year, and she's on medication, tablet Telma 40 milligram, and she has no other medical comorbidities, no history of previous surgeries, no history of any radiation in the past, no history of any intake of any antithyroid medications in the past. Next slide. She takes a mixed diet and has a normal bowel and bladder habits. Her sleep-wake cycle is normal, and she doesn't have any habit of smoking or no history of any alcohol intake in the past. So she is a postmenopausal, 6 years. Patient attained menarche at 15 years of age. Her cycles are regular with average losses, and she's P2 L2 with normal vaginal delivery and no history of any other abortions. Slide. Coming to the family history, she has no history of any uterus enlargement in the family members, or no history of any head and neck malignancies or ME and associated diseases in the family. Next slide. So summarizing my history, patient is 56-year-old lady, was homemaker and a resident of Kolkata, recently diagnosed with hypertension. Came with complaints of swelling in the anterior aspect of the neck since 3 years, and which was rapidly increasing in the size since the last 4 months to reach the current size, with discomfort over the swelling for the past 2 months, with no other pressure symptoms.
We'll take a little break here and sort of dissect the history that you're given.
Yes, sir.
Specific question for Professor Guru Shantappa, sir. Is it okay for a student to say that there was no history suggestive of overactivity or underactivity of the thyroid, hyper or hypothyroidism, and leave it at that? Or should he mention the salient features of those findings?
Sir, if he has found out that there is nothing suggestive, I think it is accepted for a postgraduate.
Okay.
By mentioning or concluding in the history that there is nothing like hyper or hypo.
Okay.
But if there is some, like a few features, like just a weight loss without anything.
Yeah.
Or the patient feels restless. Even 1 or 2 symptomatology of hyper or hypo, I think he has to elaborate. If there is nothing that is accepted. Sir.
Fair enough. Ravi, you want to say something?
Sir, I wanted to know, the thing is, in his presentation, there is a mixture of, some of the symptoms, in patient's own words, and some of the symptoms, having a medical connotation like anterior aspect of the neck and things like that. Is that acceptable, or should it be, history should be completely in patient's own words? And again, that question to Professor Guru Shantappa.
Instead of anterior, I think if we can mention it as front of the neck.
Okay. That's what I thought.
Yeah, I have no doubt it has to be in the patient's words. I was about to make that comment. There are technical words. It should not be used at all. in your presentation. You must say front of the neck, okay, and all the dimensions.
Strider again is a
Strider
medical-
is not, is not something that you use.
Okay.
Okay, yeah, noisy breathing is what you must use. It must be in the patient's words.
Okay,
And
sir.
when you mention sizes, you do not mention the exact size, but pea-sized swelling or a lemon-sized, average-sized lemon, things like that. Layman's terms.
Okay,
It is something which you have to do. And I would throw the question to other postgraduates here. Janani, is there anything else you should have mentioned or anything else in greater detail?
Sir, no, sir. No, sir. In history, he has covered everything, sir.
Okay. He mentioned radiation.
Yes, sir.
Is there anything that you should have mentioned more about radiation?
In past history, maybe no, sir. No, sir.
Radiation to the neck and chest, right?
Okay. Yes,
If
sir.
the patient has radiation to the abdomen or the lower limb, why would he get a cancer thyroid?
Yes, sir. Yes, sir.
Okay, so that has to be more specific. Similar to that, are there anything else that you can think of in the history?
Any treatment in to the skin dermatological treatment in the young childhood?
Okay,
uh,
that is again radiation for acne.
acne,
That's
sir.
fair enough. Radiation mentions. This was the one I had in mind, MEN associated disease. Now, when you're giving a history, MEN, what does it mean? You know, does the patient tell you my family had MEN associated disease? It won't happen, right?
Yeah,
So what should you be asking there in that regard, Hari?
Sir, any history of malignancies, sir? Like
multiple malignancies.
multiple malignancies in the English.
Either in the neck or in the abdomen. Any features suggestive of hypercalcemia or increased calcium, like
Tetany.
tetany. Even mention one, spasm or tetany or tightness of the muscles, something in layperson's terms, so that you know that you have asked for the history. Guru Shantapa sir, I had another interesting thing here. See, she is postmenopausal 6 years. Her goiter is for 3 years. So is the menstrual history very important to mention in detail?
It's not important, sir. Once he has committed that it is the postmenopausal status, earlier history is not relevant for the present case.
Yeah. So if the patient has some thyroid disease during her menstrual phase, then perhaps you have to mention that. And my final comment, and of course it is open to other seniors to make other comments afterwards. My understanding is that when you talk about personal history, particularly in a thyroid case, it is always better to put everything together to think of thyro or thyrotoxicosis or hypothyroidism and mention a list of things, including weight, sensitivity to cold or otherwise, in other patients, menstrual disturbances and bowel habits, as a separate block by itself, or can it be diffusely dispersed among other historical headings like personal history or otherwise? Guru Shantapa sir.
Sir, if the patient has symptomatology and want to highlight that yes, he has got toxic features, it is better to present in the history itself rather than mentioning under some heading. Because you want to convey that yes, with a neck swelling, these are the symptomatology. Means you are conveying something physiological and anatomical.
Yeah.
Sir, at the point about radiation, just I wanted to inform the students.
Yeah.
Always when the question comes about radiation, keep a few points in mind. One, what earlier we used to ask like radiation to the neck and the chest for some malignancies, more commonly the lymphoma in like about 10 years back or in a younger age group. nowadays not a very well accepted treatment modality because we have other modalities. Commonest what we don't elicit is the dental X-ray. There is an evidence that repeated dental X-ray without a thyroid protection or a thyroid shield, which all the dentists are supposed to have in their clinic compulsorily. If a person has got a repeated exposure to dental X-ray, he is more prone to have thyroid cancer. That is more than the exposure to lymphoma, radiation therapy, or chest disease.
Right.
Please remember this one. And second, as a student, you need to know everything about radiation-induced thyroid cancer. Sometimes this is where you will be caught. What is that malignancy which is commonly occurs? After how long duration of radiation? What radiation exposure will induce thyroid cancer? What is the mechanism? So there will be a lot of questions on that. So you should be ready with the answer with radiation-induced thyroid cancer.
So can you mention those briefly so that we cover that quickly? Yeah.
Hari, you know?
Sir, malignancy associated with the radiation is papillary carcinoma, sir. So in the for a latent period of 20 to 30 years before that, low dose radiation, sir. That is
10, minimum duration required is 10 years, not before 10 years.
Okay.
So after 20, 30 is too long a period.
Okay.
So 10 years, what is mentioned in the literature, commonest is papillary. And if you compare these cancers with de novo cancers, so where there is no radiation-induced cancer,
okay, sir.
Okay, radiation-induced, they are little aggressive than de novo cancer.
Okay, sir.
And invariably, they may have some metastatic deposits in the lateral neck. Okay, so if you know a little bit of this, that is more than enough.
Thanks.
All right. Any other comments, Ravi, Shrikant?
Hari,
yes, sir.
I think your presentation lacks the punch, lacks the continuity, and this. And I think it's very stuttered, and I think you need to improve your presentation. And there is a lot of grammatical mistakes that you make, which I think you should try and avoid, because I think small things irritate the examiner when they are examining 20 people. These small things will irritate people.
Okay.
I see Shrikar in the panel. Welcome, Shrikar. You have any comments?
Shrikar Pai.
Ramkrishna?
No, sir, I joined little late, so
all right.
I joined when Dr. Gulshan was talking.
All right, go ahead. Hari, please go ahead. Yeah.
So coming to the general physical examination, the patient was examined after taking verbal consent on a well-lit room in the presence of female attendant with adequate privacy. She was conscious, well-oriented to time, place, and person, moderately built, well-nourished, and well-hydrated. Her BMI was 22.8, and her pulse rate was 82 per minute, measured in the right radial artery, which is regular and adequate volume, and there is no delay. And blood pressure was 140 by 80, which was measured in the right brachial artery in the supine position. And respiratory rate was 18 per minute, and she is afebrile. So there was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, pedal edema, or pretibial mixed edema, and there was no tremors or eye signs. Next slide. So coming to the inspection, swelling of size approximately 9 to 6 centimeters, situated in the anterior aspect of the neck, with slightly more towards right than the left side, and it extends superiorly till upper border of thyroid cartilage, inferiorly 3 centimeters above sternal notch, and bilaterally till the anterior border of the sternocleidomastoid muscle. And the surface of the swelling appears smooth with well-defined margins, with lower border of the swelling visible, and the swelling moves up with the deglutition. The skin over the swelling appears normal, and there were no scars or sinuses, no dilated veins over the neck or chest region, and no other visible swelling in the neck. So this is a video showing the swelling moves with the deglutition. You can see the enlarged swelling moves up with the deglutition. Yes. Next slide. So upon palpation, findings of the inspection confirmed, and there were no sign local rise of temperature or tenderness.
All the margins are clear. Lateral margins, is it clear or is it?
Sir, it was clear, sir, but when palpation, I will explain it now, sir.
No, inspection, is it clearly seen?
Shrikant, what is it you wanted him to say?
It is diffuse margin behind the sternomastoid, no?
Yes, sir. But I was able to see, so
And that's what I'm seeing.
okay, sir.
Bilaterally, it is seen till the anterior border of the sternocleidomastoid. You prefer him to say, and I agree with you, that it seems to go under the anterior border, deep to the anterior border of the sternocleidomastoid.
Okay, sir.
That's what I think he's trying to say. And not
Thanks.
you're not sure of, that's not the end of the lateral border.
Okay, sir.
You know, it goes under or deep to the anterior border of the sternocleidomastoid.
Okay.
That's a way more appropriate statement. Okay, go on.
Okay. So well-defined swelling of size 10 into 7 centimeter in the thyroid region, and both the lobes of thyroid gland and isthmus are enlarged, and it extends superior till the upper border of thyroid cartilage and inferior till 3 centimeter above the sternal notch, and laterally right side extending beyond and under the sternocleidomastoid muscle, left side and anterior border of sternocleidomastoid muscle.
So on palpation, it stops at the anterior border of the left anterior, sternocleidomastoid.
Yes.
But on the right, it goes under the SCM.
Yes, sir.
All right. Okay.
So the surface of the swelling was nodular, regular, well-defined margins, a variable consistency with soft to firm areas, and lower border of the swelling is palpable. And the swelling is mobile in horizontal direction and moves with deglutition. And bilateral carotid pulses palpable, and the trachea is palpated in the midline. There are bilateral cervical lymph nodes, no lymphadenopathy, and the cervical spine on examination was normal.
Yeah. There is a comment from Ramakrishna: left more than right, or vice versa. What do you?
Right more than left, sir.
Okay. Go on.
Looking at
the we will come to we'll stop here at the local examination.
Okay, sir.
There's one thing that I think you were expected to mention, you didn't in the very beginning. Can you think of something? It's regarding the position of examination.
Okay, sir.
So what do you think you missed out?
A patient in the sitting position with neck flexed.
Flexed or in the neutral position?
Neck slightly flexed, sir.
Okay. Slightly flexed is probably, somebody would agree, but neutral is probably a better terminology. Okay, and what is your position in relation?
Sir, my position on inspection will be sitting in front of the patient, sir.
Okay.
For palpation, it should be from behind the patient as well as from.
So examine from both behind and in front of the patient.
Yes, sir.
Just like you mentioned as a routine, everything, with a chaperone, a well-lit room after consent and all that.
Yes, sir.
This is something that I think people expect you to mention.
Okay, sir.
Okay.
Okay,
Shrikar, are you there? Shrikar?
Is it necessary to know all the methods?
Sir. Yes, I'm there. Only thing I think he didn't tell on palpation is carotid pulsation.
He did.
Yeah. Okay.
He did mention it. The next question I have is, you have to wait question to Shrikar and Professor Guru Shantapa. Does he have to, as Shrikant was saying, should he volunteer to say how he did all these palpation, or you wait for the examiner to ask you or show you how he did it?
Sir, I would say there is, yes, sir. It begins with the attitude of the patient and how I have examined. So it always begins with that.
Yeah.
So I have because these particular swellings are supposed to be specific in how you have examined, how you have not. So it's always better to.
What I meant was, when he says yes, carotid pulse palpable, should he first mention how he looked for it and where he looked for it, or can he just say it's palpable and wait?
No, it is expected of him to mention in the beginning only.
Right, Guru Shantapa, sir.
Sir, about carotid, I think if you just commit that whether it is palpable or not, if it is not palpable, where else it is palpable.
Okay.
Then the examiner will definitely ask, how did you palpate? Then he can.
Okay.
In the beginning, with the attitude of the patient.
From the general examination, about cyanosis being, I think you should avoid in presentation of a thyroid swelling.
Okay.
You will be inviting many unwanted questions,
Right.
and you will try substantiating by some means, and you will
Right.
end up with a lot of discussion there itself.
Okay.
So you should know what exact points, relevant points pertaining to thyroid in general physical examination.
Right.
Very important, because routinely you people mention what all things, even in hernia also you'll be mentioning this.
Yeah.
So try to practice what exactly you want to highlight in general.
Yeah. Can you?
And
Okay, sir.
Yeah. Hari, can you then, according to what he has hinted, Professor Guru Shantappa, what are the things that you'll be looking for and mentioning in general examination?
Sir, pallor I will be mentioning, sir.
Pallor in thyroid case, very important.
Yes, sir.
Why would you think it's very important?
Sir, maybe not in this case, sir, but
Yeah,
so for example, in malnourished,
in a thyroid case, specific for thyroid. Yeah, go on. I don't think pallor is very important, but what else?
What I was highlighting was that only, those points.
Yeah.
Okay.
Is it important? It is not important.
Not
in thyroid.
important, you see.
Fine.
That's exactly what he was saying. That's why I said, what are the things that you give importance to?
Okay. So generalized lymphadenopathy and edemas, these are important, sir.
Generalized lymphadenopathy, Hari. You're
Why
not
generalized?
Okay.
Exactly.
Related to thyroid, sir, is
lymphadenopathy and
asking.
thyroid.
Yes, sir. Cervical. Okay, sir.
Yeah. Somebody has a hypermetabolic rate in toxicosis. Say, what will he have? He'll be sweaty.
Sweating.
That's one thing you might mention. All right.
Tremors.
If he is hypothyroid, how would the skin be?
Dry skin, sir.
Dry skin.
Thickened
Okay.
frog skin.
Okay. So
Yes, sir.
dry skin. Like that, go on. What would happen to the pulse?
Sir, one doubt. Actually, I was about to I returned it, sir, but since the patient is not hypothyroid, that's why I didn't mention. Should I mention like general all the?
No, please understand. What sir is saying is, don't mention like in everything that you mention about lymphadenopathy, koilonaikia, clubbing, and all that.
Fine, sir.
Whatever is relevant to thyroid, like the skin, the pulse, its rapidity, perhaps an atrial fibrillation or a bradycardia. All right.
Sure, sir.
And yeah, and if anything,
Sir, what is getting confused? Because in this case, everything is normal.
Yeah.
Hari, what I insist
Yes.
in this case, because it is normal, what you should be highlighting? Sir, pulse rate on radian is rate around 80 per minute, normal volume, not bouncing.
Yeah.
Yes,
Okay, regular, normal volume and the rate. That
Okay.
ends there. Okay.
Yes.
If there are signs of toxicity, you should mention about tachycardia, that is invariably high rate. Once there is a tachycardia, you should highlight on collapsing nature. Is it a high volume pulse? Once you say it is high volume, next immediate presentation should be collapsing or not.
collapsing on that.
Once you say it is collapsing, you should mention the blood pressure. We will be looking to that. Once you mention blood pressure, invariably the recording will be high systolic, normal diastolic, and increased pulse pressure. We'll be correlating whatever you are presenting. Examiner will be correlating that with the sequence of presentation.
Okay, sir.
That highlights that you know what exactly happens to the hemodynamic system in toxicosis.
In toxicosis.
Okay, sir.
Okay. Yeah.
Okay.
All right.
And we'll be checking sometimes if there is a pre-tibial mixed edema in a given case. In a case of thyrotoxicosis, have you noticed that?
Okay, sir.
Have you noticed that? If it is not there, don't highlight. In this
Okay,
case,
sir.
we don't expect. That is how you should present.
All right.
And in the local examination, I saw in the inspection, Lakshman sir was asking what is the position. I would have been more happy. You would have mentioned, sir, inspection I did sitting in front of the patient, palpation standing behind the patient. Means you have given a clear-cut idea that what is that you are examining. You got the point.
Yes, sir.
All right.
And scars and sinuses. Is it relevant? Has it got it? There is no history of previous surgery in the past. And what is that you want to convey by mentioning scar and sinuses for a case of anterior neck swelling? If the swelling would have been lateral, it has got a meaning that yes, you are keeping a possibility of tubercular lymphadenopathy.
Yes, sir.
So don't mention scars and sinuses. Routinely, all of you mention this for a neck swelling.
Okay.
Not required. And like the earlier mentioned, borders are well defined. Invariably, thyroid swelling borders are not well defined because it goes underneath the muscle.
Okay, sir.
Okay. So once you say move the deglutition, I insist the next immediate point should be lower border. both on inspection and palpation. They should come one after the other. Once you say it moves up, lower border is made out. By mentioning these 2 points, you are highlighting that yes, it is a case of thyroid swelling, which is not extending into the mediastinum.
Okay.
See how they go hand in hand. So immediately it should come. In palpation, you mentioned movement with the deglutition later after presenting everything. During inspection, you mentioned lower border made out after some time, after 2-3 points of movement with the deglutition.
Okay.
Okay, fine.
Understood. Yeah.
Go on, Hari.
So coming to the systemic examination, bilateral air entry present and is equal, and normal heart sounds S to S1 heard, no murmur. And neurological examination, no focal neurological deficits, no tremors, and normal deep tendon reflexes were elicited. And abdomen unsolved, non-distended, no organomegaly. Next slide. So I'd like to summarize the case. She is a 56-year-old lady, homemaker and resident of Kolkata, recently diagnosed with hypertension, came with complaints of swelling in the anterior front of the neck for 3 years and rapidly increasing the size for the last 4 months to reach the current size, with discomfort over the swelling for the past 2 months with no pressure symptoms. On clinical examination, a well-defined swelling of size 10 into 7 centimeter in the thyroid region involving both the lobes of thyroid gland and isthmus with nodular surface and variable consistency, moving with deglutition with no cervical lymphadenopathy, no eye signs, and clinically euthyroid. So with this, I'd like to give the provisional diagnosis of multinodal goiter, clinically euthyroid.
Well, when you mention something like this, you need to justify it, right?
Yes, sir.
Why would you even think of carcinoma thyroid in this patient?
That will be a differential diagnosis, sir.
I'm just asking for a differential diagnosis. See, okay, you talked about a nodular surface.
Okay, sir.
In a euthyroid patient. Multinodular goiter is something I would accept, even though I would have liked you to have mentioned whether it is nodular or bossyllated. What is the difference between the two?
Sir, size of that, sir. I'm not sure.
Correct.
So
Bossylation, there is no specific defined size. But if it's a smaller nodule, it is multinodular, it's nodular surface. If it is a larger nodule, it is a bossylated surface. So if you have a diffuse bilobar involvement, it is likely to be a larger nodule and a bossylated surface. But that is, I'm not holding it against you. Calling it multinodular is quite acceptable. So that is fine. But why are you thinking of carcinoma thyroid in this case?
Sir, first she comes into the high risk age, sir, more than 55 years. And also there is a history of rapid increase in the size for the last 4 months, sir.
Okay.
And also associated with the discomfort.
Okay.
So these are the reasons I kept with.
2 reasons. So, okay, I'll grant it to you, but it's still, it's a lady. So that's less likely to be, if you look at the gender, it's less likely to be a cancer. What about any other differential diagnosis that you would put even above carcinoma thyroid after the MNG?
Thyroiditis.
Yeah, some kind of inflammatory thyroid pathology.
Yes.
Why would you not consider that? Would that not give you, there is a diffuse enlargement, right? Apart from the nodularity of the cell, diffuse enlargement involving the whole gland, some increasing in size, some discomfort. So would you not put that as one of your differentials?
Yes, sir, I will.
Yeah, that has to come in. Okay. Whether you put it above, I would have put it above carcinoma thyroid, but if you had put it even below that, I wouldn't mind that, but that has to figure, because you cannot stop at 2 diagnoses, one cancer and one multinodular. There are other pathologies for the thyroid.
Okay, sir.
Okay.
Like Hashimoto's thyroiditis.
Yeah, that is, that kind of inflammatory disease, or it's a whole class of things that can occur. And that's what I was trying to say. Ravi, you have anything to add?
No, I agree with you, sir. I think he has to mention. I think, as you said, it may not be wrong to think of the carcinoma, but it needs to come lower in the pecking order.
In the pecking order. That's what I meant. Niranjan?
Sir, nothing, sir. Same, sir.
Yeah. Guru Shantappa, sir?
If there is a tenderness in the examination, probably I will insist upon this thinking, sir. If there is tenderness.
Yeah. Otherwise, are you happy with what he has mentioned now? Multinodular goiter.
Otherwise, yeah, MNC and those 2 points for possibility of malignancy.
All right.
But local examination, absolutely, there are no points in favor of cancer.
Cancer
Local
at all. Only in the history you have 2 points.
Sir, but can we justify rapid increase in growth in multinodular goiter? That was the only question. He said rapid increase.
Yeah, you have a bleed in one of the nodules, for example.
But
So
that will be acute, no? He said 4 months.
It depends on the degree of bleed and like that. So you can have some increase in size, and of course, you cannot take every word of the the patient's history at face value. But so by and large, we go by the generality of statements, and so I would have, as I said, some kind of inflammatory pathology should be mentioned, but Guru Shantappa says it's not necessarily required. That's fine. That's a point taken. So how do you proceed, Hari?
Sir, I would like to investigate the patient,
Just
sir.
one more point, Lakshman sir, if you don't mind.
Please come in.
There is, in the examination, generally we expect certain special tests on thyroid. One of the important tests is Cocker's test, which I think he didn't mention. Pardon me if I missed it.
No, because, yeah, go on.
Cocker's test is important to rule out tracheomalacia, stridor on a compression of bilateral gland is one of the classical things. And
would you expect it even in a relatively small goiter like this?
It depends on the time it has been there. So I felt it's a larger one, relatively larger one, around 8-10 centimeters. So we would use it, and consistency, whether there's any variability in consistency is also quite important. In such large,
I thought he mentioned it. No, Hari, you mentioned it?
Yes, sir.
Yeah,
Sir.
variable consistency.
Yeah, variable consistency is something he has.
Next page, next one, sir.
Okay, sir.
Yeah,
Okay.
yeah,
So we would expect certain special tests for thyroid, especially Cocker's test.
Cocker's, what else?
There are Cocker's test, and if it is a smaller one, then you use a thumb to feel for the remaining nodules. So these are the tests which we would expect.
2 of them you would expect. Okay. All right.
That's the thing. Because in say like in hernia, in thyroid, there are certain special tests.
Yeah.
So you have to try and mention it. So it really helps. In that.
All right. Okay.
Thank you, sir.
All right. Go on, Hari.
Yes, sir.
Investigations. Yeah.
Sir, I would like to investigate this patient, sir. First, I'll ask for thyroid profile. So based on thyroid profile, I'll ask thyroid profile and ultrasound of the thyroid, sir. So and in ultrasound, based on the findings, for example, if it is a nodule of size of 1.5 centimeter, 2 centimeter more with high suspicion, I will ask for FNAC of that swelling, sir. Okay, sir. If it is if there is nothing, when would you not ask for an FNAC? Based on the ultrasound test, when would you not ask for an FNAC? Sir, if there is it is a benign findings and no nodules, sir, I won't ask for an FNAC, sir. Okay. Would you agree with that, Ravi?
I didn't actually follow exactly what he said.
No, my question was, he said based on the ultrasonography, I'll ask for an FNAC. So I asked him, what ultrasound finding would you have in mind when you would not ask for an FNAC? And his answer was, if it's a benign swelling as described on ultrasound, I will not ask for an FNAC. You also mentioned if there are no nodules, right? Yes, sir. Yeah.
But would you expect that in a patient like this, where you clinically feel there are multiple nodules?
No, sir. Here, this patient will take, sir. But generally, sir was asking, like, when will you not?
When will you not? Yeah. If you think it is, generally enlarged, vascular, possibly thinking of either, Hashimoto's or Graves, then you may not need to get an FNAC.
Yes, sir.
Yeah.
Okay. So you got an ultrasound next. I agree that you get the ultrasound next. Yes, sir. Yeah. What is it? what are the salient features of this report?
Sir, this report shows that possibility of the right lobe, sir, which is enlarged, measures around 18 into 12 mm, sir. So with the comatale classification, possibility of malignancy needs exclusion, I mentioned, sir. So this is ultrasound finding for this patient, sir.
Yeah.
So
You
the patient
have
definitely.
the film. Can you show that comatale calcification?
No,
is there
sir.
a film in this?
No, sir. No, sir. I didn't get a film from this patient, sir.
Okay. Now that brings us to the so-called thyroids. What are the features? Let me go to Janani for this. What are the features on a scan that would tell you that there is possibility of a neoplasm?
Sir, in ultrasound, malignant will be hypoechoic.
Hypoechoic. Poorly defined margins. Agreed. Agreed.
High vascularity.
Okay.
And microcalcification will be there.
Good.
And it can be cystic. Sir.
Say that again. Voice faded.
And
in the thyroid itself.
Cystic or solid?
Yeah. We'll go to the.
It will be cystic or solid.
Yeah. Usually solid, right? When hypoechoic, if it's fluid, it's unlikely to be neoplasm. So it is a solid lesion. Yes, it's hypoechoic, poor margins, extrathyroidal extension. Vascularity is debatable. Yes, if you agree, I'll accept if you say that. Microcalcification. Anything about the size?
Size, it will be the size will be large than
the is there something more specific than large? Actual dimension given?
It will be tall rather than wider, sir.
Correct, taller rather than wide, and 4 centimeters in the largest diameter, the largest dimension. Okay, some people mention 3, but most people agree on 4 centimeters in the largest dimension. So these are the possibilities. Okay. So in this, you have a hypoechoic, hypotoechogenic mass lesion, measures largest size is 18 millimeters. Okay, there is some calcification. All right. So what do you do next? The isthmus and the left lobe appear pretty normal. Yeah.
So I would like to get an FNAC of that lobe swelling.
Okay. What kind of FNAC would you get? Would you ask for a direct blind one, or is there anything else?
No, sir. I will ask for an ultrasound guided FNAC, sir.
Ultrasound guided is probably better. It's a pretty small lesion, so you would like to do that. Theoretically, not commonly practiced. Is there any other modality that is coming into vogue to look for possibility of malignancy?
I didn't get you, sir.
One up on ultrasound, a further refinement of an ultrasound, any investigation that you know of?
Sir, Doppler elastography.
Elastography. Not necessarily Doppler. Doppler is most for vascularity.
Okay.
This is elastography.
Stiffness, high stiffness of
nodule. Correct. If it is more stiff, it's likely to be more malignant.
Yes, sir.
Okay. Did you have an FNAC on this patient?
Yes, sir. I do have, sir.
Yeah.
The next page, next one, sir. There's actually one more thyroid they repeated next. I don't know why, sir. Okay. This is a FNAC report of the patient, sir.
Yeah.
It shows cytological features of papillary carcinoma of thyroid. So impression was papillary carcinoma of thyroid, sir.
All right. Can I bring in Guru Shantappa, sir? Anything else you would like to add to what has been said so far, sir?
Yeah, just I wanted his opinion about the first thyroid report which he has put. Can you put that first one? First one? Yeah. Any comment on this, on impression, what the sonologist, with due respect to their report?
Yes, sir. They have mentioned about the this one, sir, probable malignancy, but there is no thyroids.
Impression, he has mentioned goiter. Goiter is a layman term. Any thyroid is a goiter. It cannot be a phenological diagnosis.
Yes, sir.
You should have. That's why probably you people have repeated the ultrasound. The next report is a nice way of putting the thyroid report.
Yes, sir. The thyroid was also mentioned.
This is how the report should be put.
Yeah, you have to specifically mention a nodule.
Okay.
And as he has rightly done, you give a TIRADS classification now. That is something that is expected of an ultrasound report of the thyroid.
Yes, sir.
Okay. All right. I'm looking at the chat box again. Shrikant, clinically, can you give a diagnosis of thyroiditis? Yes, I would have thought so. It's not, it's one of the differentials that you can consider. But as Dr. Gurushantapa was saying, he would like to see tenderness on the swelling before he considers that. That's one way of looking at it. That's acceptable to me too. Right thyroid nodule, thyroid, something that's good. And when you have a carcinoma, an FNAC, what do we talk about when we have an FNAC for thyroid?
Sorry, sir.
There is a classification of the FNAC.
Yes, sir. Bethesda system of reporting, sir.
Bethesda.
Yes,
So tell me a little bit about it.
Sir, it is having 6 categories, sir. Category 1 will be a non-diagnostic or unsatisfactory report, and category 2 is benign. And category 3 is ATP of undetermined significance or a follicular lesion of undetermined significance, sir. So, and 4, 5, 6 is important. 4 is a follicular nodule or suspicious for follicular nodule, sir.
Yeah.
4th one. Yeah. And category 5 is suspicious of malignancy, and category 6 is malignant, sir.
Right. They have included one other highly complicated term, which actually I don't understand. I read it some time ago. It has something to do with follicular neoplasm of undeterminate something. There is even a short form for that. Gurushantapa sir, you are aware of it, or do you expect people to know about it?
Sir, it fits into fourth Bethesda 4.
Yeah.
Otherwise, it doesn't have much information.
Much significant. Yeah, it's a new thing that they have introduced in the last, I think, couple of years or so. So it's something, but I think it's better that you know about it, but because somebody may ask about it. Now, how do you proceed with this? Is there anything else that you would like to ask about at this stage?
Why should you correlate clinically? How to correlate clinically FNAC finding?
Sir, with our findings of clinical findings, sir.
The clinical finding does not match up with the FNAC, then is it rule out?
This is the standard. I think it's not, Hari, it's not a question to you. I think Srikanth was just commenting how you can't clinically correlate if the cytology shows papillary carcinoma. It has to be papillary. It is the final court of justice. So you can't again clinically correlate it. I think Srikanth was just commenting on that. That's all.
Okay, thanks.
Yeah, to answer you further, Srikanth, I think it just depends on the size of the nodule. If it's a larger nodule, you can easily say it is,
if I am 100% sure it is benign, and if he gives papillary CA, then
you have to accept that it is papillary CA. You cannot be 100% certain on clinical examination. As Ravi was saying, pathology FNAC is the final court of justice, and so final court of appeal, as they say, and so you have to treat it as papillary carcinoma. Yeah. So, what would be how do you proceed with this, Hari?
Sir, for this patient, I would like to our surgery, sir.
Okay.
Yes, sir, and total thyroidectomy, sir.
Tumor markers and all you mentioned, man.
So tumor markers for papillary.
Would you want to do a thyroglobulin estimation?
Yes, sir. Thyroglobulin. Sorry, sir. Thyroglobulin has to be done, sir.
Is it a requirement pre-op?
Sir, for the post-operative, we do it can be.
Actually, it's a operative marker. Or if
Shrikar, is thyroglobulin a requirement pre-op for all thyroid neoplasms?
If you have a baseline, it would be useful, but it's a usual marker for post-operative follow-up only, sir.
Yeah, I mean, what I mean, thyroglobulin is likely to be high in the pre-op state when the tumor is still there.
Yes,
the thyroid is still there.
Sir. It's as sir was asking, tumor marker. So one of the marker is thyroglobulin.
Yeah, but that is after you take out the gland, right?
After.
Yeah.
No, that is as a follow-up, you check whether thyroglobulin is elevated, which is indirectly evidence of recurrence.
Correct,
But if
correct.
you have,
Correct me if I'm wrong.
Yes, sir.
You do a total thyroid.
Yes, sir.
Get the thyroglobulin to be 0.
Right, sir.
If it is not 0, you probably think that there is a thyroid remnant or an extra
no,
thyroid.
sir.
Let me finish.
Thyroglobulin is
Let me
only
finish. Let me
yes,
finish. Let me finish. So the point I'm making is thyroglobulin has to be 0 after you have done a complete thyroid excision.
Yes, sir.
And if there is a recurrence later, thyroglobulin keeps going up. And so you obviously follow it up in the post-op phase.
Post-op.
But is a pre-op thyroglobulin, you see the baseline for you must be 0. That is at the post-op level.
Post-op level.
Yeah. So what would be the significance of a pre-op thyroglobulin?
It doesn't make a major significance, sir.
That was the point I'm making. Gurshantapa sir, Ravi, what are your views?
Sir, I think you have to, people have to differentiate this with the CEA.
Yeah.
See, carcinoembryonic antigen for colon cancers, there are people who are non-secretors. So if you do a CEA pre-operatively and if it is high, then it assumes significance post-operatively because you know this patient is a secretor. So if the CEA drops and then goes up again, then you know there is recurrence. But I agree with Dr. Lakshman fully. There is no need for this thyroglobulin to be done pre-operatively. I think it's post-operative with significance of recurrence in the post-operative follow-up.
In the current scenario, you know, I think that two things, the so-called tumor markers, which is thyroglobulin in this case, and genetic studies, mutations, neither of them is important in this particular case. Genetic studies would take importance in two situations. One of them is if you're looking at a familial disease, particularly in the medullary carcinoma, not papillary carcinoma. And two, if you have advanced disease, when you want to give targeted therapy. Nowadays, targeted therapy have come into being. And when your surgery is something which is either not offered at all, or if there is recurrent disease, genetic profiling has a role to play in thyroid disease. But in the average case, correct me if I'm wrong, the other seniors, the average case, when you have a situation like this, I think you can go ahead with surgery. Any other comments?
Before, I would be very important is the surgery is the most important for papillary CA. So one of the most important thing is ultrasound. I don't know how good it is, but we have to check out for lymph nodes. So I was really waiting for seeing whether lymph nodes are involved in ultrasound. We may have to consider a proper ultrasound before going
clearly
ahead.
Shrikar has clearly mentioned that there are no lymph nodes.
No lymph nodes.
Clearly mentioned in ultrasound. That is for sure.
For sure. Okay, sir.
All right. So is there an option to total thyroidectomy, Hari?
Yes, sir.
Yeah.
I would like because the swelling.
What are the points for and against? You see, what is the option to a total thyroidectomy here? What other operation can you do other? That's the way, you know, that's what I meant. What other operation would you do other than total thyroidectomy?
Sir, hemithyroidectomy.
Hemithyroidectomy.
Yes, sir.
So what are the advantages and disadvantages of the two?
Sir, hemithyroidectomy, no longer patient have to be put on thyroid medication, sir. So that will be the advantage, sir. So, but there are some indications for total thyroidectomy for high risk patients.
Sorry?
Some high risk patients for indications for total thyroidectomy, they have to undergo total thyroidectomy, sir.
All right. So what are those high risk patients?
Sir, for if the nodule is more than 4 centimeters, sir,
okay,
or any extra thyroidal extension is there,
yes,
or any cervical lymph node is positive,
agreed,
or poorly differentiated tumor,
yes,
and any not any previous history of radiation,
lymphovascular invasion.
Yes, sir.
Sex of the patient, male or female. It is called what classification? AMIS or AMIS or AGIS classification.
Okay, so you're right. You're good in saying that. So that is precisely why I asked you this question. This
Yes, sir.
patient doesn't fit into the high risk category. 1.8 centimeter lump, differentiated papillary thyroid, no extrathyroidal extension. So would you offer hemithyroidectomy to this patient?
Yes, sir.
Yeah,
I
you
can-
said total thyroid. So you can't be both, you know, you have to take a
Okay.
decision. But I agree with you. I was being a devil's advocate.
Okay.
I would still not offer hemithyroidectomy, sir. I would still do total thyroidectomy. If so, why?
I will say high risk patient in terms of age.
Hey, no. Not like that. You cannot
Yes.
tell low risk and high risk in the same
In the
breath.
same breath, right?
Okay.
Age is only one of them, but in other features of the risk, you know, degree of risk, it is actually low risk.
Okay, sir.
Okay, so yeah, because
What type?
papillary can be multicentric.
What
Okay.
type it is? Papillary is multicentric. That's the thing.
Okay, so
Okay.
when you say you don't have to give L-troxin this patient, it is incorrect. That is the point I
Okay.
was trying to make. Why
Thanks.
would you, even though the patient has the other half of the gland, why
Okay,
would
sir.
you want to give them L-troxin?
Understood, sir.
Tell me, why would you want to give them L-troxin?
Sir, if it is not done, like hemithyroidectomy is done, so no need is what I was trying to make.
Yeah,
sir.
but I'm saying you're wrong in saying you should not give, you know, you have to give even if it's hemithyroid. Why would you do that?
Sir, suppression.
Just gave you a hint that this is multicentric, right?
Okay, yes, sir.
So what does it do? What you're right, you mentioned it, but be very specific and clear about it. What does it do? Giving L-troxin.
Sir, it will make again.
This tumor is TSH dependent.
Dependent.
So even if you have the other half of the gland,
Okay, sir.
you would give L-troxin to make sure that the patient's TSH is low,
Okay, sir.
so that the other small foci of neoplasm, possible neoplasm, will not grow. That is the logic behind it.
Okay.
Why would you even want to do hemithyroid versus a total thyroid? Why would you even consider it? Why not total thyroid in everybody? These are very simple things you have to answer, Hari.
What
This
is
is
the
because
risk
of the
of
side effects.
risk of total
Risk
thyroid?
of total thyroid. What are the two things you're worried about?
Sir, I was worried about parathyroid gland excess.
Yes,
and then injury to the
recurrent laryngeal.
recurrent
So if
laryngeal.
you dissect on both sides, you have a higher chance of having these damages. So you would like to avoid it if possible, but at the same time, we now have the expertise to do a total thyroid safely.
Okay.
And so you have to give them L-troxin anyway, even if you do a hemithyroid. And it is even more important if it is follicular. It is papillary in this case. If it's follicular, you have to do total. Why? What would you do if there is metastatic disease?
Sir, we will be giving radioiodine.
Correct, radioiodine therapy. And if you have half the thyroid gland sitting there, can you give?
Sir.
Sorry?
No, sir. It will take it, sir. We can't give radioiodine.
Yeah, everything will go into the thyroid, so it won't go to the metastatic site.
Okay.
So you cannot afford to have a thyroid in situ when you're contemplating radioiodine.
Okay, sir.
So these are the reasons why you would like to do a total thyroid.
Okay, sir.
Okay, I will stop here and invite comments from the seniors. Srikanth, you want anything to say?
Sir, as far as papillary is a total thyroidectomy only if it is multicentric. All other factors you can go for hemithyroidectomy and regular follow-up of the patient.
Yeah. Okay. How do you know whether it's multicentric or not? These multicentricity is microscopic many times.
Yeah.
Yeah. So that's why the standard now is total thyroid. Okay. There is one controversial area. I didn't get into it because it may confuse the postgraduate. What is a microcancer?
I'm not sure, sir. Less than 1 centimeter, sir.
Correct. You can be sure of that now. Anything less than 1, this is not micro because it's 1.8. If it is less than 1 centimeter in the largest dimension, it is a microcancer. There's a controversy in that. Some people say you don't even have to operate. That's not what the international guidelines say. All the guidelines say that you have to operate even in the microcancer. But many of them, there are 4 or 5 guidelines, and there are differences between these guidelines if you look at them. Some of them say you can get away with a hemithyroid with TSH suppression for microcancer. Others say even for a microcancer, go ahead and do a total thyroid. Okay, so if somebody asks you about a microcancer, this is what it is. That's all you need to know. But I can tell you that when somebody asks you about microcancer, you have probably passed the exam and they want to see if you know a little more about it. Okay, so comments from Ravi?
I think, yeah, I think though there are different schools of thought, I think most of them are converging towards total thyroidectomy.
Yeah.
I think you have to really justify not doing a total thyroidectomy these days.
Yeah. Okay. Yeah. Guru Shantapa sir?
Does papillary cause extra thyroidal extension?
Yes, sir. It can.
Yes, it can do. Yes, it can. It can grow outside the capsule. It can, if it's left alone, it can involve the muscles around and all that. A lot more common in anaplastic, but papillary can do that. And papillary goes to the lymph nodes a lot more than the follicular, which goes through blood vessels to, what are the common sites of distant metastasis for follicular?
Sir, long bones and flat bones and lungs, sir.
Lung and bones.
Skull bone. Yes,
correct. Sir. Lung and bones. That's right. Guru Shantapa sir?
Sir, this case probably total thyroidectomy will be accepted answer.
Yeah.
Because of the one is the age of the patient. Second, clinically both the lobes are palpable. Both the lobes are involved clinically, even though sonologically it shows one nodule and that nodule is cytologically positive. Since it's a bilobar disease with a FNAC being positive, I think the answer should be the total thyroidectomy.
Yeah.
And that classification of or putting the patient or categorizing the patient into high risk and low risk, that comes after doing the surgery in the form of hemithyroidectomy, where you get a histological perspective. For a solitary nodule, you classify that patient, that categorized patient into ASIS or MASIS criteria, and then take a decision of doing a revision total or observation.
Yeah.
So otherwise, just with a FNAC report and sonological size, classifying the patient into high category, low category, and taking a decision of doing hemi or total, probably it is not the right way. So this particular case, the treatment is total thyroidectomy. And second, like Hari,
yes,
sir was asking justification. You got the point. Justification for your surgical procedure.
Okay.
It holds good in any diseases. You take first disease per se. We are talking about thyroid here. Is it a unilobar disease, bilobar disease? What is the cytological report? What is the age of the patient? Sex of the patient. Okay. So put on how does it spread? And we are talking about a well-differentiated cancer. And papillary is known for intrathyroid deposits, either in the form of lymphatic spread or it is a multicentric. Both the reasons are applicable. Mention all these points so that examiner will be very happy. Means we will understand that yes, you know about the disease.
Right.
So those are the points of justification of total thyroidectomy. Okay.
Understood.
And
Understood.
once you said the disadvantage of doing total thyroidectomy is parathyroid and recurrent. And as a postgraduate student, you should know the incidence also. What is the incidence of hypocalcemia following total? What is the incidence of recurrent laryngeal nerve palsy following total? Okay. That you people, and details of each one, like unilateral, bilateral, what is the anatomical difference between the right recurrent, left recurrent, which is a more likely nerve to be injured, or parathyroid, which is a likely parathyroid. How do you prevent? When do you expect the person to develop hypocalcemia? Everything. What are the types of hypocalcemia in the post-operative period? How it is managed? Everything. We may not be able to discuss in the CD, but you should know everything about that because they are the common questions and common entities and easily manageable.
Okay, sir.
All right. Shrikar, any final comments?
Just to add, say if there was a level 3 or level 4 lymph node, what would be the surgery that is planned?
Sir, total thyroidectomy with modified nuclear section, sir.
Modified or central?
So level 3, no, sir?
Yeah, level 3. So,
yes, sir.
Okay. So you would want a modified neck dissection. Why
Yes,
is it so? Why is it very important, neck dissection?
Since lymph nodes are involved, so to remove the disease. Sir.
What happens if there is residual lymph node disease?
Spreading will be.
The very important thing is it is not so radiosensitive as is the main gland. Okay. So it's always better surgically than as a radioactive iodine. So radioactive ablation may not be very amenable for metastasis in the. Okay. Otherwise, it's been a very extensive discussion. So I think most of the points are covered.
Niranjan? Maybe he's left, has he? Yeah. Okay. Final comments, Ravi?
Hari, I think you presented the case. There was a little bit of sort of hesitancy, but the discussion part of it was good. I think you should just improve your presentation a bit. Otherwise, I think overall you've done well.
Yeah, sure, I would agree that overall you did well. What I would like you to read up about, please give him, we have no time to discuss all that, otherwise we could have done it. But the point that Dr. Guru Shantappa made is very important about the technicality of thyroidectomy. Okay, where do you expect the parathyroids to be, the superior, the inferior? I'm repeating it just so that you look it up and prepare yourself for your exam. What is the presentation of hypocalcemia if it occurs? All right, and if you have done very well, they will get into, as I mentioned earlier, the P53 and RET genetic markers and the need and the role for targeted therapy. Okay, if you see the cancer.gov site, it will give you all the information. I keep looking at it from time to time. I recommend that all of you do it. It gives you very succinctly the latest that happens, and that is something which is not normally clinically done here, but targeted therapy is coming, and these are applicable not to an early cancer like this, but for recurrent or extensive disease. Okay, and it is good for you to read up about it. And I can tell you that if somebody is asking you about it, you have passed.
Yes.
All right. Okay. Thank you very much, everybody, for a very fruitful and a useful discussion. I sincerely hope you keep coming and participating so that we can all collectively learn. Before we go, I sincere request to all of you here and your students and your colleagues. Janani from our department has put out a questionnaire about the role of tele-teaching, as it were, the Zoom meetings and the teaching, perception of teachers and students. Kindly fill it up. We find that very few PGs have done it. So those of you who are here, please induce and request your PG friends to fill the form so that we get meaningful results out of that survey. Thank you very much and good night.
Thank you,
Good
sir.
night, sir.
Good night, sir.
Thank you, sir. Thank you, sir.
Good night.